Okay, this patient has cyclic dysuria hematuria with the means. This patient with has cyclic dysuria and hematuria with means, most likely endometriosis. The ectopic implantation of the endometrial glands and stroma. Although some patients with asymptomatic diagnosed incidentally, those who are symptomatic, those who are symptomatic often have varying presentation and examination finding that depend on implant location. This patient likely has deeply infiltrating implants in the bladder. These endometrial implants shed with monthly means, causing bladder pain and suprapubic tenderness. These ectopic endometrial implants, subsequent fibrosis can cause subsequent the ectopic endometrial implants and subsequent fibrosis can cause characteristics anterior bladder wall tenderness, and nodularity as seen in this patient. When the menstrual cycle ends, the classic the symptoms classically resolves until the next cycle. Definitive diagnosis of endometriosis is during surgical direct visualization during surgical exploration. Conservative management include OCP, NSAIDs. Surgery can remove the visual lesion, but recurrence is common. Okay. This patient with dark urine has heme positivity on urine dipstick, but a few urinary RBC findings that occur with myoglobinuria or hemoglobinuria that occur with myoglobinuria and hemoglobinuria in the absence of muscle X rhabdomyolysis. This patient with a mechanical aortic valve most likely has hemoglobinuria, a condition in which free hemoglobin is present in urine. Increased turbulence through prosthetic valve causing shearing forces on the RBC, which can lead to intravascular hemolysis and release of hemoglobin. Hemoglobinuria occurs when free hemoglobin exceeds both the saturation of the serum haptoglobin and the resorptive capacity of the proximal tubule. The result in urine that is red hemoglobin pigment or brown methemoglobin pigment with the detection of the heme positive blood on urine dipstick, but with only 0 to 2 RBCs in the urine, which is normal and considered negative, in contrast to hematuria 3 or more than 3 RBC on high power field. The next step in evaluation of pediatric patient with suspected hemolysis is complete blood count to confirm the presence of and assess the severity of anemia, which is likely the cause of this patient's exertional fatigue. Additional findings Additional findings of mechanical intravascular hemolysis include low heptoglobin, increased LDH, increased reticulocyte count, schistocyte on peripheral blood smear. Okay, I don't understand the middle part of the thing, like hemoglobinuria. Why we are doing like 0 to 2 RBC, no muscle pain. So myoglobinuria excluded. There is no increase in CK, so myoglobinuria excluded. Now hemoglobinuria. Now explain me.
This one or this one?
In the hair, in here. Yes. Yes. It, it's not more than 3 RBC. It's not hematuria. Then why CBC? Why not other tests? Why CBC? That's my question. We are we are dealing with the urine. Why we need the blood? Okay. But this patient has mechanical valve like bicuspid aortic valve to, to infective endocarditis. But there is no fever. Yes. Mm, okay. Why not warfarin? Okay, okay,
finding of
okay. This clinical picture of this patient highly suggestive of acute tubular necrosis. Highly suggestive of acute tubular necrosis following hypovolemic shock. A serum B1 to creatinine ratio 10. A serum B1 to creatinine ratio 10 to 15 is typically seen in acute tubular necrosis in contrast to prerenal azotemia, which is more than 20. Other findings that support the diagnosis is urine osmolarity of 300 to 350 milliosmol per liter, but never less than 300. Urine sodium is more than 20. Than Fena is more than 2%. Prolonged hypertension from any cause can lead to ATN. The hallmark finding of urine analysis are granular casts consisting of renal tubular epithelial cell. This is a non-specific but very sensitive finding of ATN. Okay,
Papitas.
yes, granular cast, granular model. Fun. Okay. Muddy brown like granular crust is ATN. Red blood cell cast is glomerulonephritis. White blood cell cast is interstitial nephritis and pyelonephritis. Fatty cast is nephrotic syndrome, and broad and waxy cast is end stage renal failure. Waxy cast is end stage renal failure. In the educational objective,
Oh,
this point is very important. A muddy brown granular cast is ATN. Red cell cast is glomerulonephritis. The white cell casts are interstitial nephritis and pyelonephritis. Fatty is nephrotic, and broad and waxy is chronic renal failure. Chronic renal failure. Okay. I missed this slide. This patient's elevated serum creatinine, hematuria, proteinuria. This patient elevated serum creatinine, hematuria, proteinuria, and hypertension is consistent with glomerular injury. She has and she has evidence of multi-system involvement, including constitutional symptom, fatigue, weight loss, inflammatory arthritis, skin lesion, erythematous plaque with scales, pigment change, scar concerning fortisquad lupus. These manifestation developed after a Caribbean trip, suggesting photosensitivity with sun exposure causing DNA damage. Photosensitivity, sun exposure causing DNA damage and inflammation. This presentation is highly concerning for SLE flare complicated by lupus nephritis. Because early diagnosis and treatment can reduce the morbidity. Early diagnosis because early diagnosis and treatment can reduce the morbidity and mortality of the lupus nephritis. A kidney biopsy is indicated for any patient. Urgent kidney biopsy is indicated for any patient with known or suspected SLE who have evidence of kidney involvement, where evidence of kidney involvement, abnormal proteinuria, active urine sediment, elevated creatinine. In addition to ruling out of, in addition to ruling out other SLE related kidney diseases, thrombotic microangiopathy kidney biopsy established the diagnosis of the lupus nephritis and defines the histologic class which determines treatment. The histologic classification of the lupus nephritis is related to glomerular site, mesangial, subendothelial, subepithelial of immune complex deposits formed by autoantibody against nuclear self-antigen, anti-double-stranded DNA bound to DNA. Clinical manifestation range from asymptomatic proteinuria and/or microscopic hematuria for mesangial immunocomplex class 1 to glomerulonephritis for subendothelial immune complex and subepithelial immune complex produced nephrotic syndrome. Treatment is determined by histologic class 6 lupus nephritis describes end-stage scarring more than 90% of the glomeruli that is likely benefit from the patient. Okay, yes. Mesangial class 1 minimal mesangial proliferative. Clinical feature is asymptomatic microscopic hematuria. Close monitoring. Subendothelial 3 and 4 focal proliferative diffuse proliferative. In here, clinical features is glomerulonephritis with or without nephrotic syndrome, immunosuppressant, mycophenolate, and steroid can be given. Subepithelial class Subepithelial class 5 membranous large proteinuria nephrotic syndrome, immunosuppressant, mycophenolate, and steroids can be given. Class 6 advanced sclerosing has scarring more than 90% of the glomeruli with no residual inflammation. Proteinuria should be treated with renin-angiotensin blockade and sodium restriction. This patient has calcified lexis, also known as calcific uremic arteriolopathy, which is characterized by systemic arteriolar calcification and soft tissue calcium deposition with local ischemia and necrosis. It occurs most commonly in patients with long-standing end-stage renal disease who are on hemodialysis and have uh, had an kidney transplant. Pathogenesis likely multifactorial. Proposed mechanism include high calcium and phosphorus produced with mineral deposition in vascular walls. Deficiencies in inhibitors of vascular calcification, phytoin A and chronic inflammation, calcified lexis, presents with painful subcutaneous plaques and nodules that can be violaceous or purpuric. The nodules can also progress to ischemic or necrotic ulcer and become infected, leads to sepsis. Mortality is high. Calciphylaxis is most common in areas of adiposity, trunk, thigh, and in contrast to atherosclerotic ischemia, usually presents with intact peripheral pulse. Lab studies can show high serum PTH and hyperphosphatemia, which is common with ESRD due to reduced renal clearance and phosphate. Although hypercalcemia, not hypocalcemia is a risk factor, normal calcium level do not rule out calciphylaxis because tissue calcium concentration may be higher due to local inflammatory changes. Okay. Yes. Calcific uremic arteriolopathy calciphylaxis. It is arteriolar and soft tissue calcification. Arteriolar and soft tissue calcification. There is local tissue ischemia and necrosis. Local tissue ischemia and necrosis. Risk factor is ESRD, hypercalcemia, hyperphosphatemia, hyperparathyroidism, oral anticoagulant, painful nodules or an ulcer, soft tissue calcification on imaging. Soft tissue diagnosis require skin biopsy, arteriolar calcification occlusion, and subintimal fibrosis. Management is analgesia wound and wound care. Treatment of risk factor high phosphorus, high calcium, and optimization of dialysis. It is uric acid stone, renal colic with no stone identified on abdominal X-ray. Renal colic with no stone identified on abdominal X-ray can be due to the following: radiolucent stone, uric acid and xanthine stone, small calcium stone less than 1 to 3 millimeter, and non-stone ureteral obstruction, blood clot or tumor. This patient has uric acid stone which are radiolucent, uric acid stone which are radiolucent on X-ray but can be seen on CT scan. Uric acid stone account 5 to 10% adult nephrolithiasis. Adult nephrolithiasis cases are most commonly seen in patients with persistently low urine pH and hyperuricosuria. Low urine pH is a major risk factor because the solubility of the uric acid significantly declines as urine pH decreases. Conditions that may be persistently acidic urine include chronic diarrhea, due to enteric bicarbonate losses and diabetes mellitus or metabolic syndrome, unclear metabolism. Treatment include hydration, alkalization of urine, low purine diet, uric acid stone, low purine diet, alkalinization of the urine, pH 6 to 7. Oral potassium citrate is recommended because increased urine pH increases uric acid solubility and promote dissolution of stone. In addition, citrate is a stone inhibitor. Citrate is a stone inhibitor that reduces crystallization. Allopurinol can be added if symptoms recur despite initial measures, especially if hyperuricosuriia occurs. Okay.
So they are
These older patients vomit, voiding symptoms, dysuria frequency, hematuria, acute right-sided flank pain, and hydronephrosis. In the absence of nephrolithiasis are concerning for bladder cancer. In the United States, most cases arise from the bladder surface epithelium, urothelium, due to chronic exposure to chemical carcinogen in the environment or in the cigarette smoke. Older older adults are most common. Older adults are most often affected and typically have one or more than one of the following: hematuria, tumor growth drives the formation of new blood vessels. Hematuria tumor growth drives the formation of new blood vessels that may bleed, leading to gross or microscopic hematuria. It is classically present throughout voiding and not associated with painful voiding. Hydronephrosis, bladder outlet obstruction. or ureter obstruction by the tumor that leads to hydronephrosis, which can be associated with flank pain and acute kidney insufficiency. Elevated creatinine as seen in this patient bladder cancer can be unilateral hydronephrosis obstruction of ureteral orifice and or bilateral hydronephrosis obstruction of the urethral orifice, avoiding symptom bladder tumor. Bladder tumor can reduce bladder capacity, cause retrosal muscle hyperactivity, or result in bladder neck or urethra obstruction, leading to varying manifestations such as nocturia, frequency urgency, dysuria. Adults age more than 40 who have unexplained hematuria with no evidence of infection, pyorrhea, bacteriuria, glomerulonephritis, red blood cell cast, dysmorphic RBC, or nephrolithiasis require investigation of the bladder cancer. The gold standard initial test is urine cystoscopy, which allows direct visualization of the bladder wall and biopsy of the suspicious mass.
55 men. What's the
Does he has any sort of kidney problem? Like, is it reassurance? So in the CT scan, the whitish one, like white point, these are the cysts, or these black one. Okay, okay. This patient has likely had viral gastroenteritis. This patient likely has viral gastroenteritis. However, his CT scan of the abdomen has a simple renal cyst on the inferior aspect of the right kidney. Such cysts are most commonly seen in patients aged more than 40. They are benign, often discovered often discovered incidentally by radiological examination. Most of the time, cysts do not cause hypertension, flank pain, hematuria. Hypertension, flank pain, hematuria, infection occurs rarely. When the renal cyst is found, when a renal cyst is found on imaging, it is often possible to differentiate from a simple renal cyst or a malignant cyst. malignancies based on radiologic feature mm, based on radiologic features suggesting of malignancy include irregular ovals, multilocular heterogeneous compound, solid or cystic, and contrast enhancement. Contrast enhancement. Okay. Incidentally discovered cysts with benign features discovered cysts with benign features require no additional follow-up evaluation or imaging, and patient may be reassured. Okay. Sorry.
It's normal.
Okay. This patient with an unremarkable CT scan of the head experienced a seizure due due to hyponatremia. Although serum osmolality is often obtained first in this patient with hyponatremia, it is typically most useful if a patient has a predisposing factor. If patient has a predisposing factor for hypertonicity such as significant hyperglycemia causing translocational hyponatremia or isotonicity such as hyperlipidemia, lipemic serum, sometimes causing lab artifact pseudohyponatremia. Otherwise, in most patients, hyponatremia is likely hypotonic. Hyponatremia is likely hypotonic. Hypotonic hyponatremia can be further subclassified based on volume status: hypovolemic, euvolemic, and hypervolemic. This patient's presentation is not consistent with volume depletion, so she likely has euvolemic hyponatremia. Major cause include syndrome of inappropriate antidiuretic hormone, and primary polydipsia. Malnutrition is less likely in this patient. And, the patient use of selective serotonin reuptake inhibitor is a risk factor for SIADH, where generalized anxiety disorder and nephrolithiasis predispose to primary polydipsia. Drinking as an excessive amount of water to avoid another stroke. Urine osmolarity measurement differentiate primary polydipsia from SIADH. If low urine osmolarity less than 100, urine osmolarity less than 100 reflects excess massive water ingestion, leading to dilute urine. This is consistent with primary polydipsia. And high urine osmolarity reflects of the urine water being pulled out of the urine in response to ADH, resulting in concentrated urine. This finding is consistent in the setting of excess ADH. Okay, sorry. Polyuria is another factor that can help distinguish between these disorder present in primary polydipsia, absent in ADH. Polyuria is another factor that can help in the disorder present in primary polydipsia, absent in SIADH, but confirming polyuria in a timely manner can be difficult. Limited ability to establish a history in this patient, making urine osmolarity measurement is particularly helpful. Okay,
And by
okay, it's hepatorenal syndrome. Do you want me to read the explanation? Okay, next. Anion gap. What is anion gap? Looks like uh, okay. You calculate. Yes, yes. So lactic acidosis cannot be happened. Wait, this patient has metabolic acidosis, normal anion gap, loss of bicarbonate, which results in loss of bicarbonate. This patient's magma likely due to type 1 RTA. Type 1 RTA, in type 1 RTA, urinary pH is more than 5.5. These patients' urinary pH is 6.8, so it's one of the important points. The major three types of RTA, all of which the major three types of RTA from impaired bicarbonate excretion by alpha intercalated cell in the distal tubule. Hypokalemia is typically present due to reduced hypokalemia is typically reduced hypokalemia is typically present due to reduced bicarbonate reabsorption and increased urinary pH. 5.5 is expected due to markedly impaired capacity to acidify the urine. Impaired hydrogen excretion, so impaired urinary acid excretion. So in type 1, impaired urinary acid, that means hydrogen excretion by alpha intercalated cell. Okay. Type 2, impaired bicarbonate reabsorption. Impaired bicarbonate reaction in the PCT. 1 for DCT, 2 for PCT. Okay, and hypokalemia is usually present because distal tubular hydrogen excretion is able to somewhat compensate for the impaired proximal bicarbonate reabsorption. Urinary pH is variable, often less than 5.5. Type 4 RTA results from reduced aldosterone activity, leading to impaired hydrogen and potassium excretion in the collecting duct. In contrast, type 1 and type 2 RTA hyperkalemia is typical. The urine pH is less than 5.5. Okay. Yes. Increase gastrointestinal bicarbonate loss. Severe diarrhea is most common cause of NAGMA. Intracellular shift of bicarbonate occurs with excess sodium chloride leads to NAGMA. These these and most other etiologies of acidosis occur with intact distal tubular hydrogen excretion. Therefore, low urine pH less than 5.5 is expected as the Kidney can appropriately acidify the urine and excrete excess acid. These patients' high urine pH in the setting of metabolic acidosis suggest a defect in renal acid handling. Okay.
Okay. Can we stop?
Yes. Tomorrow we can start new block. These questions are repeated, maybe. May, this is the last block, I think so, isn't it? Because most of the question is repeated, as far I found. So, what are how many? You have told near about 200 question is left. Okay. So, or tomorrow we can do what? Ophthalmology NT. Okay, we can do allergy immunology and poisoning first. Then, okay, okay, okay. Bye bye.